Think about the last time you got a paper cut. Or, maybe you scraped your knee on a sidewalk.
Right, you probably just washed it, slapped a bandage on it, and then completely forgot about it until it was, like, time to peel the plastic off.
Exactly. You get a cut, you forget about it, it heals. I mean, we treat it like an automatic software update that's just happening in the background.
It really does feel that way.
Yeah.
We're so accustomed to our bodies just, well, fixing themselves that we completely take the mechanics for granted. You bleed for a minute, you wait a few days, the cut is gone.
But the sheer cellular violence and, honestly, the coordination happening under that Band-Aid is unbelievable. Welcome to this deep dive. Today, we're looking at the clinical biology and history of wound healing.
And it turns out almost everything our parents taught us about treating a scraped knee is completely wrong.
So wrong. It's not just a passive event where skin magically glues itself back together. It is a highly orchestrated, incredibly noisy biological construction site.
Yeah, and we're finally moving past this simple binary idea in medicine of a wound simply being closed or open.
Right. When you look at the cellular data, tissue repair is a measurable four-step sequence of events. If any one of those steps fails or gets interrupted, the whole system just stalls out.
Okay, let's unpack this. Because before we can understand how nurses and doctors actually treat wounds, we need to know what the body is doing on its own at second zero.
The very beginning, yeah.
Right. The moment that paper cut happens, we enter phase 1, which is hemostasis.
Right, hemostasis is the emergency response. And this phase is measured in minutes. The very instant your tissue is breached, your blood vessels violently constrict.
Like they just clamp shut.
Exactly. They clamp down to reduce blood loss. And at the exact same time, platelets flowing in your blood detect the damage and start clumping together for injury site.
So the platelets are like microscopic sandbags plugging the leak.
That's a great way to visualize it. They aggregate and trigger this incredibly complex chain reaction called the clotting cascade. And the end result is a fibrin clot.
Fibrin is a tough, stringy protein. It weaves through the platelets to lock them in place. But here is the crucial part.
Okay.
That clot is a plug, yes, but it also acts as a scaffold. As the platelets settle, they release a massive wave of signaling molecules into the surrounding tissue.
Oh, so they're setting up a biological flare.
Precisely. They're broadcasting an SOS to recruit the specific immune cells the body needs for the next phase.
Which pulls us right into phase 2.
Right.
Inflammation, which, from what I read, usually dominates from day 1 to day 4.
Right.
The SOS goes out and the first responders arrive. Specifically, a type of white blood cell called neutrophils.
Neutrophils are fascinating. They swarm the area within hours. You can think of them as tiny Pac-Men.
Okay, Pac-Man.
Their entire job is to seek and destroy bacteria and basically chew up microscopic debris. Once they've cleared the initial danger, the heavy machinery rolls in, and these are the macrophages.
Macrophages being like the site managers for this whole operation.
Exactly. They continue clearing debris, but more importantly, they secrete growth factors.
Got it.
These chemical signals are what actually summon the builders to the site to start repairing the tissue. But this phase is where public perception really diverges from clinical reality.
Oh, for sure. Because when a patient hears the word inflammation, they immediately assume something is terribly wrong. They look at a wound and see redness, warmth, swelling, and they feel pain.
Right, they panic.
I mean, yeah, if my cut is hot, red, and swollen, my immediate thought is that I have a raging infection.
It's the most common patient fear.
Oh.
But during days 1 to 4, those cardinal signs of inflammation are perfectly normal. In fact, they're mandatory.
They have to happen.
Yes. The redness and heat are simply the result of your blood vessels dilating to rush those neutrophils and macrophages to the site. The swelling is just the nutrient-rich fluid leaking into the tissue to help them work.
Wow.
It's visible proof that your immune system is doing its job.
Okay, so if we think about this like a damaged house hemostasis, is the emergency crew rushing in to shut off the water main so the basement doesn't flood?
And then inflammation is your demolition crew. The macrophages show up with dumpsters, tearing out the ruined drywall and sweeping up the glass so the actual carpenters have a clean, sterile foundation to work on.
I love that analogy. And those carpenters finally show up in phase 3, which is proliferation, day 4 to day 21.
Right.
The site is clear, and cells called fibroblasts move in. And from what I understand, fibroblasts are essentially like microscopic spiders spinning webs of protein.
That's a perfect image. They're spitting out collagen. Specifically type 3 collagen, which is, Well, it's a bit weaker and more elastic, but it fills the gap quickly.
Okay.
And while they do that, the body initiates angiogenesis, which is the sprouting of brand new blood vessels to feed these working cells.
So the plumbers are putting in new pipes.
Right. And this combination of new collagen and new blood vessels creates what clinicians call granulation tissue.
Granulation tissue, right.
If you've ever looked into a deep healing cut and seen that bright red, kind of bumpy, incredibly fragile tissue at the bottom, that is granulation tissue. It's the new foundation.
And while the foundation is being poured, the roof is being built. Epithelial cells start migrating across the very top of the wound to cover it back up in new skin.
Yes, exactly.
But there was another cellular mechanism in this phase that I just couldn't believe. Myofibroblasts.
Wound contraction. This is incredible. In certain wounds, these specialized myofibroblasts actually act like tiny muscles.
Muscles inside the cut.
Yeah, they anchor themselves to the edges of the wound and physically contract, pulling the borders of your skin closer together to reduce the size of the hole.
That is just microscopic tug of war. Millions of cells heaving the skin shut. Which leads us to the final phase, which is maturation or remodeling. And this can take anywhere from a few weeks to 2 whole years.
It takes a long time.
So the interior decorators come in to finish the house. The weak type 3 collagen is slowly replaced with much stronger type 1 collagen. The fibers cross-link, reorganize along the lines of mechanical stress, and that raised red scar eventually flattens out.
But here is the biological reality check that catches so many people off guard.
What's that?
That remodeled scar tissue, it never regains its full original strength.
Wait, never. A surgeon's scalpel permanently downgrades the structural integrity of my skin? Is there really no way to train the tissue back to 100%?
No way at all. At its absolute best, a fully healed human wound reaches about 80% of its pre-injury tensile strength. It is a patch job.
Just 80%. That's wild.
Yeah. The collagen fibers in a scar are aligned in a single direction like a bundle of ropes, rather than the complex interwoven basket weave pattern of original uninjured skin. So visible skin closure on the surface does not mean the tissue underneath is identical to what you were born with.
So if human biology intrinsically caps out an 80% patch job, how do medical professionals decide when to intervene?
Well,
Because you'd naturally think the goal of modern medicine is always to stitch every single wound shut immediately to give the body a head start. But looking at the clinical frameworks, that is absolutely not the case.
no, it's entirely contextual. Clinicians classify wound closure into 3 distinct categories based on how they manage the tissue edges. We call these the 3 intentions.
Okay, walk us through this toolkit.
The first is primary intention, and this is what most people picture when they think of stitches.
Right, the classic needle and thread.
Exactly. The wound edges are perfectly approximated, meaning pulled together and secured with sutures, staples, or surgical glue very shortly after the injury.
Okay.
Because the edges are touching, the body doesn't need to build much granulation tissue. You get a very thin, linear scar, and it heals quickly. A clean surgical incision is the classic example here.
That feels pretty straightforward, but then you have secondary intention. And this is where the medical team deliberately leaves a wound completely open.
Yes, they do.
They just pack it with dressings and let it heal from the bottom up. The body has to fill the entire chasm with granulation tissue, and those myofibroblasts have to pull the edges together from scratch.
That's right.
But I have a question about the logic here. Does a nurse or doctor just look at a wound, decide it's too big to pull the edges together, and default to secondary intention? Like, is size the deciding factor?
It's a very common assumption, but actually size is secondary. The decision to leave a wound open is driven primarily by contamination and tissue viability.
Oh, okay.
Think about a relatively small but heavily contaminated puncture wound. Say, a deep bite from a stray dog.
Oh, because if you stitch a dog bite shut immediately, you're taking all that aggressive mouth bacteria and sealing it inside the tissue.
Yeah, exactly. You're locking the demolition crew inside a burning building with no way out. The bacteria will multiply, an abscess will form, and the infection will just tunnel deeper into the body.
Nice.
Right. So by leaving it open to heal by secondary intention, the body can continually flush out the debris, and nurses can clean the wound bed every single day until it fills in.
Which brings us to the hybrid approach. Tertiary intention or delayed primary closure.
This is a brilliant clinical compromise. Let's say a patient comes in with a ruptured appendix. The abdominal cavity is flooded with infected material.
Right.
The surgeon removes the appendix, cleans the area, but deliberately leaves the skin and muscle layers open. They pack it and wait for, like, 3 or 4 days.
So they are essentially waiting for phase 2, the inflammation, and the Pac-Men to do their job and clear the remaining microscopic bacteria.
Precisely. Once the surgical team is confident the bacterial load has dropped to a safe level and there's no rampant infection,
Yeah.
then they take the patient back and stitch the wound closed like primary intention.
And the stakes of getting this calculus wrong are terrifying. If a doctor gets impatient and chooses primary closure when there's still infection lingering, the complications are severe.
Very severe.
The big one to monitor for is dehiscence, where the wound literally bursts back open, and then there's evisceration.
Right. Evisceration is the absolute nightmare scenario in post-op nursing. It's when the internal organs actually protrude through the separated wound edges.
Just a total structural failure.
It is a critical medical emergency, and it highlights exactly why respecting the biological phases is way more important than just making a wound look tidy on the surface.
It sounds so precise, so calculated today, but makes you wonder how we ever figured this out. Because for over 1,000 years, the medical establishment got wound care disastrously, lethally wrong.
The dark ages of healing.
Yeah.
It is a grim history of very smart people being very wrong.
Let's talk about Galen and Hippocrates, the foundational pillars of ancient medicine. For centuries, they promoted a doctrine known as laudable
It
pus.
sounds totally contradictory to us today, but we have to understand the paradigm they were operating in.
Right.
They believed human health was dictated by 4 humors, or fluids. If you were injured, they thought the body needed to expel corrupted, toxic humors to restore balance.
Okay.
Therefore, they viewed the thick, white pus oozing from an infected wound as a good sign. They thought it was the body successfully venting the poison.
So they were looking at a festering, infected wound and saying, excellent, it's doing exactly what it should. They actively discouraged early closure because they thought trapping the pus would kill the patient.
And what's fascinating here is that this lethal misunderstanding persisted all the way until the 16th century.
Duh.
That's when a French battlefield surgeon named Ambroise Paré stumbled into a paradigm shift.
Right. In 1537, he was treating soldiers with gunshot wounds. And the standard medical practice to prevent the so-called poison of gunpowder was to pour boiling oil directly into the open wound to cauterize it.
Unimaginable torture.
Truly horrific. But during one particularly brutal battle, Paré simply ran out of boiling oil.
Yeah.
So out of desperation, he improvised a gentle dressing made of egg yolk, rose oil, and turpentine, and he applied it to the remaining soldiers.
And he later wrote that he couldn't sleep that night, terrified those soldiers would die from poison.
But the next morning, he discovered the men treated with his gentle mixture were resting comfortably. Their wounds were healing beautifully. Meanwhile, the soldiers subjected to the boiling oil were feverish and agonizingly inflamed.
He accidentally proved that incinerating the tissue might not be the best way to promote cellular repair. He realized that boiling oil was destroying the delicate granulation tissue, basically killing the builders before they could even start.
Wow.
Later in the 18th century, a Scottish surgeon named John Hunter took this a step further. He was one of the first to look at redness and swelling and hypothesized that inflammation wasn't a disease to be cured, but the body's intrinsic repair mechanism.
So he deduced phase 2 centuries before microscopes could even prove it.
Exactly.
But the laudable pus theory didn't truly die until the 1860s, right? With Joseph Lister.
Yes. Lister took Louis Pasteur's new germ theory and realized that wounds weren't spontaneously generating pus from bad humors. They were being colonized by invisible microbes in the air and on surgeons' unwashed hands.
Gross, but true.
He introduced carbolic acid as an antiseptic. He finally proved that healing was essentially a race between your tissue trying to rebuild and microbes trying to invade. Kill the microbes, and the tissue wins.
So we escape the Dark Ages, we figure out germ theory, we map the 4 phases of cellular repair. You'd think it'd be smooth sailing from there. But even armed with this biology, modern science still spent decades fighting massive misconceptions.
Because once we understood the cells, the debate shifted to the environment. What external factors actually help or hinder those delicate cells from doing their job?
Which brings us to the ultimate playground myth. I mean, every kid has heard this from their parents. Take the Band-Aid off and let the scab breathe.
Oh, it is the most stubborn myth in wound care, and we have known it is completely false since 1962.
1962.
Yeah. A British researcher named George Winter ran a landmark study using a pigskin model. He took identical wounds, covered half of them with an occlusive polymer film to keep them perfectly moist, and left the other half exposed to the air to dry out and form a hard scab.
And the moist ones healed faster.
Twice as fast. The wounds kept moist under the film epithelialized in about 3 days,
Hmm.
compared to roughly 7 days for the dry, scabbed wounds.
So what is the actual mechanism there? Why is a scab bad?
Because biologically, a scab is a roadblock. It is a dense wall of desiccated dead tissue.
Okay.
Remember those epithelial cells migrating across the surface to close the wound? If the wound bed is moist, they just slide right across like a slip and slide.
Right.
But if there is a dry scab, those fragile cells literally have to burrow deep underneath the dead tissue to find moisture, expending massive amounts of energy and time. So a scab doesn't protect the healing process, it obstructs it.
That makes perfect sense when you visualize the cells having to tunnel under the debris. Now, here's another modern biological clash that caught my eye, the inflammation paradox.
Yes, this is a big one.
We established that phase 2, inflammation, brings the swelling, the heat, and the macrophage demolition crew. But when I get a deep cut, my immediate instinct is to take ibuprofen for the pain. If I take a non-steroidal anti-inflammatory drug and an SAD, am I actively sabotaging my own healing?
It is a brutal clinical trade-off.
Really?
NSAIDs work by blocking the production of prostaglandins, and those are the exact chemical messengers that trigger the blood vessels to dilate and summon the macrophages.
Oh, wow.
So yes, you quiet the pain and reduce the swelling, but you're effectively turning away the demolition crew. By suppressing that immune activity, you are measurably slowing down the transition into the proliferative phase.
So the post-op patient is begging for anti-inflammatories for comfort, but the surgeon knows those pills are putting the brakes on the biological engine.
Exactly. And medications aren't the only roadblock. The raw materials available in your bloodstream dictate the speed of construction. The history of scurvy is the perfect illustration of this.
James Lynn's 1747 trial with the British sailors. They had severe vitamin C deficiency. The historical accounts say their new wounds wouldn't heal, but far more terrifyingly, their old, fully healed scars were spontaneously breaking open.
Yeah, it's gruesome.
I mean, why would an old scar just dissolve?
Because of how collagen works.
Yeah.
We tend to think of a scar as a permanent structure, but collagen turnover is a continuous, lifelong cycle.
Okay.
Your body is constantly dissolving old collagen and synthesizing new collagen to replace it, keeping the tissue strong.
So it's just a constant state of maintenance.
Right. And vitamin C is a mandatory biological glue, a cofactor, required to synthesize new collagen.
Oh, I see.
When a sailor gets scurvy, their body loses the ability to make new collagen. But the enzymes that dissolve the old collagen don't stop, so the maintenance cycle breaks. The body literally dissolves its own scar tissue, and without vitamin C to rebuild it, the old wounds just unzip.
That is horrifying, but the mechanism is fascinating. It proves that nutrition is literally the raw material for the site.
Yep.
If a patient is malnourished or has poor glucose control from diabetes or smokes, which restricts oxygen flow in the blood, they aren't delivering the bricks and mortar to the site.
And when those supplies don't arrive, the wound gets stuck. This is the definition of a chronic wound. The tissue gets trapped in the inflammatory phase. The macrophages just keep clearing out tissue, but the fibroblasts never show up to rebuild.
If a patient has multiple issues, say they smoke, they have diabetes, and the wound is dry, how does a nurse even begin to untangle why a specific wound isn't closing?
That is exactly why modern wound care developed the TIME framework, TIME.
Okay.
It's a dynamic clinical checklist to restart a stalled biological engine. T stands for tissue. Is the tissue in the wound bed viable, or is there dead necrotic tissue that needs to be surgically removed?
Got it.
I also for infection or inflammation. Is there a bacterial burden stalling the cells?
And M would be moisture balance, going back to George Winter's pig study.
Exactly. Too dry, and the cells can't migrate. Too wet, and the surrounding skin macerates and breaks down. And finally, E is for edge of the wound.
The edge.
Yeah, are the edges actively migrating inwards, or are they thickened, rolled, and stalled? By assessing T, I, M, and E, a clinician can isolate exactly which phase of healing has failed and correct it.
But even with perfect intervention, the body's programming isn't flawless. Sometimes the engine loses its brakes entirely, right?
Yes, in cases of keloid and hypertrophic scarring, the maturation phase is supposed to reach an equilibrium, but sometimes the fibroblasts just refuse to stop producing collagen.
They just keep going.
They keep stacking it up, creating raised, expanding, sometimes disfiguring scar tissue. It reminds us that for all its elegance, the cellular blueprint can still malfunction.
So bringing this all together, why does the microscopic life of a paper cut matter to the person listening right now? Well, it matters immensely because chronic, non-healing wounds are a silent, massive burden on the global healthcare system. Diabetic foot ulcers, pressure injuries, they lead to severe systemic infections and amputations.
But on a personal level, understanding the why behind the bandage empowers you.
Yeah.
When you understand that the redness on day 2 is your immune system working, you don't panic. When you understand that smoking starves your tissue of oxygen, or that a dry scab is actually a cellular roadblock, you stop being a passive bystander. You are actively managing your own biology.
We're running the construction site. Now, before we sign off, I promised one final provocative reality check about human biology.
Let's hear it.
We talked earlier about how adult scar tissue only ever regains 80% of its original strength. Scarring feels like a permanent, unavoidable law of nature. But according to the cellular biology data, up until roughly the end of the second trimester, a human fetus heals wounds completely scarlessly.
It is one of the most incredible phenomena in biology. Fetal tissue doesn't just patch the hole with fibrous collagen. It regenerates perfect, pristine skin architecture.
Yeah.
Hair follicles, sweat glands, everything.
Perfect regeneration. Which means that scarring isn't actually an unbreakable rule of human biology. The genetic code for perfect healing exists inside us. It's just a feature of our early developmental environment that gets switched off before we're born.
Yeah.
Which leaves you to wonder, if we all used to have the cellular code to heal perfectly without a single scar, what happens on the day medical science finally figures out how to turn that code back on for adults? Keep digging deep on that one. We'll catch you next time.